Chapter 24, Caring for Infants and Children. Objectives: review the major stages of lifespan development for the pediatric patient. You can find additional information for this in Chapter 4. Define the following terms: abuse, adolescent, croup, epiglottitis, febrile, infant, mandated reporter, neglect, pediatric assessment triangle, also known as PAT, retractions, school age, shaken baby syndrome, sudden infant death syndrome, also known as SIDS, toddler, work of breathing. Explain the various techniques that can be employed to maximize successful assessment of the pediatric patient. Explain the components of the pediatric assessment triangle. State the most common cause of cardiac arrest in the pediatric patient. Describe the signs and symptoms of sudden infant death syndrome, also known as SIDS. Explain the appropriate steps for management of a suspected SIDS death. Describe common signs and symptoms of abuse and neglect. Explain the role of the emergency medical responder in the cases of suspected abuse and/or neglect. Explain the assessment and management of the following emergencies in pediatric patients: upper airway obstruction, lower reactive airway disease, seizures, shock. Demonstrate the ability to properly assess and care for a pediatric patient. Demonstrate the various techniques that can be employed to maximize successful assessment of the pediatric patient. Demonstrate the application of the pediatric assessment triangle. Demonstrate sensitivity for the feelings of family while caring for an ill or injured pediatric patient. Recognize the emotional impact in responding to pediatric patients can have on an emergency medical responder. Value the role of the emergency medical responder with respect to patient advocacy. Alright, caring for the pediatric patient. Characteristics of infants and children. You always want to approach them slowly. Make sure you establish and maintain eye contact. Ask permission to come closer to them. Sometimes they can be very shy or nervous. Let them know someone will call their parents if you're having to deal with somebody who's not with their mother or father. Get down on the same level with the child. Let them see your face and your facial expressions, and you always want to speak to them directly. If you'll notice in the image, he's down eye level with the patient. He's got a warm, inviting face while he's assessing her. He's trying to make her feel comfortable. Alright, characteristics of infants and children. Pause to find out if the child understands what you have said or asked. Quickly determine and manage any life-threatening problems. Perform a head-to-toe assessment. Always tell children what you are going to do before each step of the assessment. You don't ever want to surprise them. Let them know when you're about to touch them. Let them know if you're going to do something that's going to hurt. Don't ever lie to children. If you lie to a child, you will completely lose their trust and you're not going to be able to gain it back during your contact with them. Offer comfort by stroking their foreheads or holding their hands. Don't direct all of your conversation to the parents. A lot of times the children can be, able to understand, and if you treat them like they aren't able to talk for themselves, a lot of times they can get their feelings hurt, and it's going to be harder to care for them. So just one thing to keep in mind, it is considered offensive in some cultures to touch or pat a child on their head, so it's best to avoid this practice if possible. Alright, work with reactions of parents or primary caregivers. Ask anxious caregivers to help you do something. If they're involved in the care of the child, a lot of times their anxiety will decrease because they feel like they're able to do something. So if there's something that they can do to assist you, or just something that you can have them do, even if it's not really going to make a whole lot of difference in the patient's care, go ahead and assign them a task. Sometimes it can help. A lot of parents will know how to manage any special pediatric medical equipment that they may have on scene. This goes Especially important if you've got children that are on ventilators or have specialized medical devices that they have to, deal with every day. The parents are going to be very proficient at dealing with this. Also, just help keep the parents calm any way you can. All right, developmental categories for children. Infants, these are going to be babies from birth to 1 year old. Toddlers, this is a child from 1 to 3 years old. Preschool, child from 3 to 6 years old. School age, child between the ages of 6 and 12. Adolescent is a child between the ages of 12 and 18. Also, just keep in mind that neonates are from the time of birth to 30 days. All right, special considerations when you're dealing with a pediatric patient. A child's head is going to be proportionally larger and heavier than the body. This makes them prone to head injuries. Gravity is going to act on their head a little bit greater than other parts of their body, so it's going to cause them to be off balance and just happen more head injuries in general. You want to handle the head of the newborn with caution because the fontanelles, fontanelles are just soft spots that have not fused together yet. Sunken fontanelle may indicate dehydration. A bulging fontanelle may indicate increased pressure inside the skull.
The Emergency Medical Services, EMS, assures that adults and children with acute illnesses and injuries receive emergency care and timely transport to the hospital. At the community level, the EMS system has ambulance units and trained emergency medical personnel who respond to emergencies.
Ambulance 2, Engine 3, respond to 557 Tendoy, unresponsive child.
The public accesses the EMS system by placing a call to 911 or their local emergency phone number. A dispatcher directs the ambulance unit to respond, takes information, and helps the caller manage the ill or injured person until emergency personnel arrive. In some communities, EMS is part of the fire department, while in other towns it is separate. Each EMS service has a medical director who establishes protocols, and state EMS offices set guidelines for training and certification of emergency medical personnel. In addition, the state EMS office works closely with hospital emergency departments and trauma centers to coordinate emergency care of patients transported by the EMS system. Children have different physiologic responses to emergencies because of their smaller anatomy and developing organ systems.
Okay, hold on. We're going to have to log roll and get the towels underneath the chair.
Small children often cannot describe their health problems. They depend on family members for security and recognition of the emergency. With the smaller anatomy, pediatric-sized equipment and supplies are essential. EMS providers need education to assess the child and recognize signs of a true emergency. Thus, in 1984, federal legislation was enacted to assure that children's special needs were integrated into the EMS system. Hospital emergency departments and trauma centers are obviously a crucial part of the EMS system. The departments establish clinical guidelines for a well-orchestrated response to serious trauma and medical emergencies for pediatric patients.
What happened, Vincent? Did the tractor...
In addition, some nurses work as volunteer EMS providers in their community. They also work as transport team members, providing care to critically ill children who need to be transferred by ground or air ambulance from a community hospital to a hospital with more advanced care.
It's table 24.1. We're not going to go through it here. It's going to be in your book. It's just a continuation of the same table. Just look for it in your book. Alright, more special considerations. Airway and respiratory systems of the infant and child are not fully developed. Infants are primarily nose breathers. Overextending a child's neck during airway management can cause the trachea to collapse and obstruct the airway. The trachea of a child is not as rigid as an adult, so if you flex or extend their neck too much, it can collapse. Now, this is just an image of a child being supine. You can see because his head is larger, his neck, his chin is flexed forward. This could cause an airway obstruction. All right, this is the same child with padding under his shoulders. You can see his neck is in a much better position. Alright, so the chest of children is much more elastic than adults. You're going to see obvious chest movement with labored or distressed breathing. Look for a loss of symmetry when you're checking out their chest. Look for unequal chest movement when they're breathing or bruising over the chest. Your abdominal organs, such as liver and spleen, are large for size of the cavity and much more susceptible to injury. So if you think about it like this, they're proportionally larger than the adults. They've got less space inside the body cavity, so they're just more likely to be injured in a child because of that reason. Trauma to the pelvic girdle can result in large amounts of blood loss into the pelvic cavity. This is true for children and adults, but just always keep in mind that trauma to the pelvic girdle can be a source of significant blood loss. You want to assess circulation, sensation, and motor function in the distal extremities. Alright, bones are less developed and more flexible. Growth plate is developing tissue in the weakest area of the growing bone. Infants and children have a large amount of total surface area in proportion to the total body mass. So if you have a burn area that is the same size on a child and the same size burn on an adult, the child is going to be affected much more severely by the same area of burn. So that's just something to keep in mind. Alright, smaller the patient, the less blood volume the patient has. Pulse and respiratory rates vary with the size of the child. Smaller children have higher rates. This table 24.3 just goes over the respiratory differences in infants and children. Adolescents that are 13 to 17 years old have a respiratory rate that's very similar to an adult at about 12 to 16. School-age children, 6 to 12-year-olds, have a respiratory rate anywhere between 18 to 30. A preschooler, which is 4 to 5 years old, has a respiratory rate of about 22 to 34. A toddler, which is 1 to 3, his rate is going to be 24 to 40, and an infant is 30 to 60. The lower you get in age, the more range you have that's considered normal. Blood pressure varies in children and depends on sex, age, and height. The time of day, physical activity, emotional moods or feelings, or physical condition can always affect blood pressure. You always want to make sure you're using the appropriate size cuff. Alright, here's a scenario. You respond to the home of a 9-month-old female who began choking on a small toy and now cannot breathe. How will you proceed? You're going to follow your CPR or your training that you learned during the BLS for healthcare providers class. You're going to alternate back slaps and chest thrusts with the infant. While you're attempting to dislodge the obstruction, the baby becomes unresponsive. You're going to move into CPR and only try to remove the object if you see it. Assessment of infants and children. You're always going to start with the scene size up. You're going to approach the child slowly so you don't frighten them. Determine scene safety. Determine the number of patients involved. Determine the mechanism of injury or nature of illness. Put on your personal protective equipment. Call immediately if additional resources are needed. Your primary assessment, you're going to obtain a general impression. It's an important indicator of the severity of the illness in the child. Your pediatric assessment or pediatric assessment triangle or PAT. This is a tool used to determine general impression of a pediatric patient. It involves the appearance, the work of breathing, and circulation or perfusion. It's figure 24.3. It's in your book. Just goes over details of the pediatric assessment triangle. On the left side of the triangle, you've got appearance. As far as appearance goes, you're going to assess your mental status, your body position, and your muscle tone. On the right hand side, you've got your work of breathing. You're going to look for visible movement, effort of breathing, and audible sounds. In circulation, you're looking for skin color. All right, a high priority infant or child is going to have a poor general impression. They may also have an altered mental status. This could include someone with an airway problem, respiratory distress or inadequate breathing, somebody that's developing shock. Airway is the first concern in care of any patient. This includes children. The infant's tongue can easily obstruct their airway. It's proportionally larger than an adult's in their mouth. Do not attempt to perform blind finger sweeps only. Remove an object if you actually see it. Provide oxygen to children by using the blow-by technique per your local protocols. Alright, this is an image showing blow-by technique of oxygen delivery. They've just got a non-rebreather mask held in the general area of the patient's mouth. It reduces anxiety and still gives the patient an increased amount of oxygen in their inhaled breath. Secondary assessment, you focus on getting the history and conducting a physical exam. For a child who is seriously injured or is sick, perform a rapid assessment. This could include a patient with a significant mechanism of injury or an unresponsive patient. All right, how might the procedures for obtaining pediatric vital signs different from the adult procedures? A lot of times the child's going to have a lot of anxiety, and you're going to have to work with the child to get them to allow you to take vital signs. You may actually also check your pulse in different locations or just do different things that may make the patient a little bit more comfortable. Alright, child responding or acting normally. Trauma patient with no significant MOI or a responsive medical patient. This type of individual can get more of a focused exam. Physical exam is going to be similar to an adult except for frightened or crying infant or young child. It may be performed in reverse order, starting at the toe and moving up to the head. This just reduces anxiety. Alright, so blood pressure is considered a late and inherently unreliable finding in pediatric patients. Why might this be the case? The reason is a child can compensate very well up to a point, and then they're going to crash. So you just got to keep that in mind. So when you're reassessing the child, their status can change rapidly and frequently. You always want to reassess the mental status, maintain airway, monitor breathing, check pulse, reevaluate skin color, temperature, and condition. You want to reassess the vital signs every 5 minutes for unstable patients and every 15 minutes for stable patients. This is a good rule of thumb for adults and children. You respond to an apartment to find a 7-year-old female supine on the sofa. Her mother reports that she has been complaining of a sore throat for several days. She appears lethargic, her respirations are shallow, and her skin is very hot and flushed, even after taking a fever reducer. How you proceed? You're going to do a primary assessment on this individual. You're going to assess her airway, breathing, circulation. As long as her airway and breathing, circulation are intact, you can proceed with your assessment. You're just going to treat the patient according to what you find. If you do find that her respirations are in fact shallow and she's not breathing adequately, of course you're going to apply a bag valve mask with supplemental oxygen to the patient to assist ventilation. Alright, managing specific medical emergencies. Alright, respiratory emergencies. This is the most common cause of cardiac arrest in infants and children. You want to review Chapter 8 for signs and symptoms and management of partial and complete airway obstruction for the pediatric patients. Just a note to take home here. Respiratory emergencies are the most common cause of cardiac arrest in infants and children. Alright, respiratory emergencies include difficulty breathing, which can be caused by a simple cold, respiratory infection, apnea, or sleep apnea, which is a common cause of SIDS, or sudden infant death syndrome. Alright, why should the EMR consider any airway problem or difficulty or breathing difficulty a life-threatening emergency in a pediatric patient? Children can't compensate as well for respiratory issues as adults can. Their muscles aren't as developed, and they can fatigue quicker than adults. So you want to definitely get ahead of that when as soon as you recognize the problem. Croup. Now, this is an acute respiratory condition that's common in infants and children. You're going to hear a barking type cough or stridor. A lot of times this will actually be relieved with cold air, so they may sound better and breathe a little bit easier when they're in a cold environment. Epiglottitis, look at your medical terminology there. Itis means swelling, and that's going to be swelling of the epiglottis. So it's swelling of the epiglottis caused by a bacterial infection. This may cause an airway obstruction. Alright, respiratory distress signs and symptoms. Wheezing or high-pitched harsh noise or grunting. Exhaling with abnormal effort. Abnormal or inadequate breathing patterns. One thing to keep in mind is when you see symptoms of respiratory distress, you do not want to waste any time listening to lung sounds or doing any further assessment before you apply oxygen. Once you determine the individual's having trouble breathing, just apply oxygen immediately. This holds true for children and adults. Alright, respiratory distress signs and symptoms continued. You also may see the use of accessory muscles to breathe. You may see the individual in the tripod position. This is also true for adults. You may notice drooling, nasal flaring. So some later signs and symptoms are going to include cyanosis, increased capillary refill time of more than 2 seconds, a slow heart rate, altered mental status. This is just the image of an individual in early respiratory distress. Notice the flared nostrils. See that the neck muscles are retracted. You may have supraclavicular retractions. Intercostal muscles may be being used. You may see seesaw respirations. You may hear stridor, grunting, suprasternal retractions, audible wheezing, and subcostal retractions. Alright, asthma can be a life-threatening emergency if it's left untreated. You want to use the prescribed medication or inhaler. Signs and symptoms of asthma are going to be shortness of breath, wheezing, and obvious respiratory distress. More signs and symptoms of asthma are going to be a cough, faster than normal breathing rate, increased heart rate, sleepiness or slowed response, cyanosis in severe patients. You want to provide oxygen with a pediatric sized non-rebreather mask or using blow-by technique. Provide assisted ventilations with a pediatric-sized bag valve mask and supplemental oxygen if needed. You're just going to have to determine that based on the patient's presentation. Not all asthma patients require bag valve masks. However, if a patient is going into respiratory failure, they're not able to breathe adequately on their own, you're going to have to assist their ventilation. This is a rescuer applying oxygen via non-rebreather mask to a child. We're assuming that she's having an asthma attack. This is rescuers providing bag valve mask ventilations to a patient that is not breathing adequately. Alright, seizures, sudden change in mental status, sensation, behavior, or movement can be caused by high fever, epilepsy, or infections. Also poisoning, low blood sugar, or also known as hypoglycemia, head injuries. Febrile seizures are caused by fever, should be taken seriously. After the seizure, it's normal for the child to be either lethargic and difficult to arouse or agitative and combative. Any child who has had seizure must have a medical evaluation. One thing to keep in mind, a seizure can be very frightening to a parent. So in addition to providing patient care, you need to reassure the patient or the primary caregiver. Alright, altered mental status in children can be caused by low blood sugar or hypoglycemia, poisoning, infection, a head injury, decreased oxygen levels, shock, or seizures. Alright, so shock can be caused for many different reasons. Some of the most common are dehydration from diarrhea and vomiting, blood loss, allergic reactions, poisoning. Shock from fluid loss occurs quickly in infants and is a serious emergency. Decompensated shock. The body's compensating mechanism suddenly fail. This is especially true in children. They can look fine, and then all of a sudden they will crash. So you've got to get in front of this early. Rapid heart rate and respiratory rate. In children, you got a weak or absent pulse. You have significantly delayed capillary refill of greater than 2 seconds. See a decreased urine output. We're not really going to see this, but the parent may be able to tell you some information if the child hasn't been urinating. That's some big concern. Mental status is also a key indicator of shock. It's often difficult to assess that in the pediatric population. So you just need to be able to determine if they're acting age appropriate or not. Alright, fever. This is the body's normal response to many childhood diseases and infections. Additional causes of fevers can be heat exposure, non-infectious disease, childhood immunization shots. A child with a high fever will be flushed. Their skin will be red and dry. Potential emergent situations could be a fever with a rash, long bouts of diarrhea and vomiting, inadequate intake of fluids, sudden spike in temperature with or without a seizure. So why might it be helpful to ask the caregiver if a fever reducer has been given, and if so, at what time was and what dose? This is important because the fever reducer may mask the signs of a more serious illness. So you just want to know when and if they gave some. Hypothermia. This is very important because children lose a lot of body heat through their heads. Children can't conserve heat very well. They're unable to regulate their temperature as well as the adult body. They can become chilled through the environment, injury, or illness. Adults need to be careful not to assume that because they are tolerating a cool environment, a child is able to tolerate it equally. A lot of times this doesn't happen and children become hypothermic without the adult or caregiver actually realizing what's going on. Diarrhea and vomiting cause is dehydration. This is large amounts of necessary body fluids through prolonged vomiting and diarrhea or decreased intake. Infants are more susceptible to dehydration than adults. Alright, dehydration and vomiting continued. Dehydration is going to be a balance of fluids in to fluids out needed to maintain the muscle and organ function. Shock can result when large amounts of fluids are lost. Poisoning, potentially a life-threatening condition that can affect any or all body systems. Drowning, this occurs with a child submerged in water, may still be alive or clinically dead. No breathing and no heartbeat, but not biologically dead, which means the brain cells are still alive. Alright, sudden infant death syndrome. This is characterized as a sudden, unexplained death of an apparently healthy baby during sleep. Most common in the first year of life, but can occur in children as old as 2 years. Causes and theories are still being investigated. Start your emergency care as you would for any patient in cardiac arrest. A lot of times, SIDS deaths occur when a baby is sleeping in the bed with the parents. Parent will inadvertently roll over on top of the baby during sleep and suffocate them. Still considered a SIDS death unless it's proven that that's what happened. Alright, scenario. You are treating an infant in respiratory distress. You notice his respiratory rate begins to slow and that his pulse drops from 180 to 60 beats per minute. What do these changes in vital signs indicate? So the child is decompensating, going into respiratory failure. You're going to have to get in front of this. If the child is decompensating with their respiratory drive, you're going to have to go ahead and start ventilating. If their heart rate gets too low, you're going to have to start CPR. Right, managing trauma emergencies in children. Trauma is the #1 cause of death in people 1 to 18 years of age. This can be from motor vehicle crashes, drowning, burns, firearms, falls, abuse, entrapment, or crushing injuries. This is an unintentional injury. It's the leading cause of death for persons between the age of 1 and 34. Just keep in mind that prevention is a huge part of helping children stay safe. Alright, burns. The rule of nines applies. The percentage of body surface area is going to be different for children than it is for adults. You can have 18% to the head and neck. In adults, that's 9. 18% to the chest and abdomen. 9% to each arm. 18% to the entire back. 23% for each leg. And 1% for the genital area. Carefully and quickly care for burned area with dry, sterile, not inherent dressings or sheets. Follow your local protocols. Burns are excruciatingly painful. Children are likely to be frantic. Rapid transport is very important. When you're dealing with suspected abuse, this can be physical, emotional, sexual. Calls involving pediatric patients can be especially difficult emotionally for the rescuer. You want to collect more information and perform assessments. Provide care without making judgment or expressing your suspicion, distaste, or disbelief. Just be sure to report this to the appropriate individuals. You want to report concerns and impressions to ambulance personnel, medical direction, social services, health department, or law enforcement per your local protocols. Mandated reporters are those designated by law to report cases of suspected child abuse or neglect. Alright, Psychological abuse. This is going to be emotional or verbal abuse that seriously affects the child's positive emotional development, well-being, and self-esteem. All right, here's a scenario to think about. You're called to treat a woman in the custody of police. She was arrested after fighting with another woman over drugs. Her children were and are present. Could this be considered an emotional and abuse scenario? And if so, why? Yes, it absolutely could be considered an abuse scenario. It's going to be a very emotional event for the child, and it can definitely affect their well-being. You're also putting the child in a very dangerous situation with the drugs and the fighting. Or neglect. This is going to be failure of patients or caregivers to adequately provide for a person's basic physical, social, emotional, and medical needs. Sexual abuse. This is physical abuse, contact or exposure of sexual exploitation by displaying or photographing children for sexual purposes or with sexual intent. Do not expect the abuser to admit to sexual abuse as the reason for the call. May call for some other reason and try to blame it on something else. Right, adults are often uneasy talking about sexual abuse. Remember that the EMR must always be an advocate for the patient, regardless of how uncomfortable the nature of the abuse may be. The situation has to be addressed, and if you suspect sexual abuse, you've got to report it. Physical abuse. This is any form of violent, harmful contact with a child or any disfiguring act performed on a child. Child's relationship with the parents or the parent's attitude towards the child or situation may be a clue to the abuse. Right, this is just an example of injuries caused by abuse and neglect. This is bruising to the buttocks. You can see it's in different stages of healing. This is just more injuries. Shaken baby syndrome. Abuser violently shakes infant or small child, creating whiplash type motion that causes acceleration, deceleration injuries of the brain. This is a serious emergency. Alright, child safety seats. Many safety seats are not installed correctly. Children are often not secured properly by safety straps or harnesses. Any vehicle crash should lead you to suspect a child has been injured. Alright, this is two rescuers removing a child from a child safety seat. Same scenario. They're applying a seat collar after removing the straps. They have now laid the child safety seat back and they're preparing to slide them onto the spine board. Alright, here's a scenario. You respond to a 3-year-old male who's been struck by a car. He's lying prone, crying, but not moving. Why might his injuries be more extensive than those of a 30-year-old who was hit by the same car? How will you proceed? Alright, so one thing to think about is this 3-year-old male has been struck by a car. The point that the car is going to impact his body is going to be different than that of a 30-year-old. So you're going to proceed just by completing your primary assessment, completing a appropriate assessment on the patient, and proceed depending on your findings of the assessment. Alright, summary. Assessment and emergency care of infants and children is the same as adults. Consider special considerations of pediatric patients' anatomy, physiology, and emotional responsiveness. Infants breathe through their nose. If this is obstructed, they may not immediately open their mouth to breathe. Be sure to clear the nostrils of any secretions that may be present. When managing the airway of an infant, make sure large head is in a neutral position, neither hyperflexed or extended. Place a folded towel under the infant or child's shoulders if needed to maintain the spine and airway in a neutral aligned position. Care for respiratory distress in infants and children immediately. For respiratory distress, provide oxygen with pediatric-sized non-rebreather mask or use blow-by technique. You always want to follow your local protocols when you're dealing with oxygen administration. For severe distress and respiratory arrest, provide assisted ventilations with appropriate device. Children tolerate high fevers better than adults. Fever that rises rapidly can cause seizures. Arrange to transport a feverish child. Arrange to transport a child who is experiencing vomiting and diarrhea. Alright, treat infants and children for shock early. Signs and symptoms of shock mean it's progressed and it's in the late stages. If you suspect shock may result from the MOI or nature of illness, provide emergency care immediately. Do not hesitate. Infants and children are frequent victims of trauma because of their size, curiosity, and lack of their fear due to the inexperience with life in general. Keep in mind that their larger head size and weight make pediatric patients more prone to head trauma. Be calm, professional, and discreet about suspicions of abuse or neglect in the presence of caregivers. Be an advocate for the child and report the abuse no matter how uncomfortable it may make you feel. Always remember your obligation to report any suspicions to the proper authorities.